This is going to be a quick run-through. You're going to hear in more detail some of the clinical features, the pathologic features of transverse myelitis, but I also want to share with you some preliminary data that we've gotten from the center and from seeing approximately 220, 230 patients over the last 18 months with the diagnosis of transverse myelitis. What we've set up is a multidisciplinary clinical center with a basic research arm that serves two purposes: to treat patients either acutely and separately in the chronic phase when they're dealing with disability. We also are examining the basic fundamental pathophysiology, what goes wrong, what causes transverse myelitis, because the embarrassing thing is that we don't know this yet. And so we're trying to do both. We involve, from the clinical aspect, neurology, neurosurgery, rheumatology, physical medicine and rehabilitation, physical therapy, occupational therapy, and urology. And many of you have been to Hopkins, and many of you have seen not only neurology, but neurosurgery or urology, etc. We have now seen about 240 patients with a diagnosis of transverse myelitis. And we are starting to develop a clinical database, spinal fluid, because most of you have had lumbar punctures done. Serology means blood studies, and occasionally, rarely, autopsy data. And this is how we are hoping to further our understanding of the disease. These are the diagnostic criteria that we have used, set forth in 1981, and I think one of the things that we may do this weekend is to decide if this is an appropriate definition or if indeed it needs to be changed somewhat. It is acute or subacute motor, sensory, or autonomic dysfunction. Autonomic dysfunction primarily means bowel and bladder problems. And many, if not most people in the acute phase have bowel or bladder problems. There is a segmental distribution of sensory impairment, hence the name transverse. A level often across the chest, depending on the level of inflammation, which defines the transverse aspect of it. We need to rule out spinal cord compression. And we need to rule out other causes, such as lupus, such as multiple sclerosis, and at least in the initial criteria, less than 4 weeks from onset of symptoms to their worst. It is a rare disease. Approximately, based on a few different studies, somewhere between 1 to 8 new cases per million people per year. And if we believe those numbers, and they may be underrepresented, you're talking about 1,400 new cases in the United States per year. Rare, but not extraordinarily rare. A lot of new cases per year. And based on the notion that people don't always completely recover, you can then make an estimate that there are about 34,000 people in the United States at any given time suffering from the effects of transverse myelitis. This is what we think about when somebody gets the term transverse myelitis. It often is wrong. And we think about trauma or MS or spondylosis, which is an arthritic process, tumors, other cancerous diseases, B12 deficiency, some types of intoxication, a blood clot or a hemorrhage into the spinal cord, a stroke of the spinal cord, an abnormal collection of blood vessels called AVM or AVF, and vasculitis, an inflammation of blood vessels. But we don't know the etiologies. And I say that etiologies because I believe, and I think most of us do, that this is a heterogeneous disorder. This isn't just one cause that we are suddenly going to wake up and identify. I think that there are probably many different causes. And you'll hear more about direct microbial infection, viruses, bacteria, post-infectious immune reactions, and even vascular injuries as we go on. I won't go through the list. There's actually 2 slides of viruses which have been shown to cause this. And this is probably not comprehensive. This list as well as this list. So there are lots of viruses that can do it, and there are many more that we have not yet even identified. And I emphasize that in many cases it's probably not a viral infection. It may be a response to an infectious agent that has been cleared. So we have looked at some features, and we're using this to try to decipher what's going on. And so let me just take you through that briefly. There are 6 sections to the study. We look at demographic information, associated medical problems, history of preceding factors, what happened in the acute phase of the transverse myelitis, and then we have a series of recovery and outcome data, which we've divided into motor, sensory, bowel and bladder, and sexual function, and then follow-up information. And I emphasize that we're just starting to look at this, so the things which I will tell you about really are very preliminary. We've collected the data over a 14, 15-month time frame, and we've got information entered and analyzed from 123 patients, though we have many more samples ongoing. Patients with other diseases such as MS, lupus, B12, HIV/AIDS were excluded from this study, and this is a subjective study, and analysis was based on the recall and reporting by the patients. We would then cross-reference that based on the medical records that we had available to us. So this is, so far, the largest study of transverse myelitis with 123 patients. And if we look at the literature, there are several others, and the N means the number of patients that they studied at each time: 32, 30, 67, 52. We have a completion rate of greater than 90%, which is a good sign. We've included clinical, serologic, spinal fluid, and radiologic data, and I've told you about the limitation which we've identified. Now, what we found so far is that 64% female, 36% male. And this was somewhat surprising because the previous studies had not found a sex preponderance. And we found a fairly significant one in that transverse myelitis is more common in women, at least according to this data. The age, the mean age, was about 44 years in our study, ranging from 2 to the oldest patient in our study was 80 years old. This differs a little bit. We have an older population than that which has been reported. The Roper study was 32 years. Other studies have actually shown 2 peaks. Basically, in the teenage years, there's a peak. There's a sensitivity to transverse myelitis in the teenage years, and then a second peak in the 30s. And we actually didn't see that. This is our histogram describing the age of our patients, and it looks fairly standard bell curve. We didn't see the 2 peaks. I'll just mention that we look for basically epidemics. We look for little hits of increased incidence, and we have not yet found that. It doesn't mean they don't exist. I have suspicions of there are little outbreaks of Memphis, Tennessee, and one in Michigan, and I've heard about others. But at least so far, we haven't found that to be the case. It needs a lot more study. Other studies that have been reported have looked at what did people present with. The one on the left here is in children. The one on the right is in adults. Pain, weakness, urinary dysfunction, and sensory. Those are the 4 cardinal features. And in the children, really none of them is uniform, is shown in all of the patients, 12 out of 25, 9 out of 25. In adults, pain in about 40%, weakness in about 30%, etc. Sensory dysfunction, numbness, pins and needles was the most common sign, and we find that to be the case as well. So 96% of patients reported numbness or sensory loss, and about 68% experienced significant pain, band-like, tightening, burning, lancinating pain. And this 68% pain, many of you know, you've experienced it, is something which has been underreported and is very, very common. Sexual bladder dysfunctions, very, very common. 94% in the acute stages of transverse myelitis, but 85% of men long after the transverse myelitis have erectile dysfunction. So it is a big, big problem. And if you look at bladder dysfunction, so requirement for catheterization is a pretty big deal. 40% in the acute phase, but even a quarter of people long-term require catheterization for bladder control. How quickly do these symptoms progress? Most studies have really shown that it's half of all the patients studied progressed to their nadir, to their worst clinical disease within 24 hours. And that's actually what we have found. About 45% progress to their nadir within 24 hours. But there are patients, 10%, 9%, 36%, who take much longer and stutter along or progress much more slowly over days to even weeks. 45% have been felt to be para-infectious, meaning related to an infection. 21% in this one study, we have not directly addressed this in our study, ultimately were found to be multiple sclerosis. 12% were felt to be ischemic and vascular, and about 21% we just never know. We don't find out what the cause was. So in our study, about 65% of patients did receive IV steroids, 52% received oral steroids, IVIG, intravenous immunoglobulin, acyclovir, antibiotics, plasmapheresis in 8%. You'll hear more about that from Brian Weinschenker. We don't know if they work. We really don't. The best data that we have actually is for plasma exchange, plasmapheresis. Now, I don't know what to make of this data, but essentially the bottom line is if we take all of our patients who are at an identical disability in the acute phase and say some of this group got steroids, some did not, is there any difference in their ultimate outcomes? No. The answer is no so far. Now, again, I don't know what to do with that because I think that there's a heterogeneous mix. I think many of you would say steroids did work for me. They helped. And we don't know that. I think that there are probably subsets of transverse myelitis patients in whom it does work, and there are subsets in whom it doesn't, and we've yet to sort that out. There are several features which we can use in the acute phase to predict how patients will do. Certainly the physical examination, retained reflexes, retained posterior column function for the clinicians helps. Some studies have shown back pain, spinal shock, abnormal somatosensory evoked potentials, and denervation on EMG. This is primarily for the clinicians, is a poor prognostic indicator. What's non-predictive is age, sex, race, whether or not you had an antecedent illness, rapidity of progression, although that's somewhat controversial, the level in the spinal cord, and what the spinal fluid showed. Essentially, if you look at the data from all of the studies, including ours, about 1/3 have a good outcome in which they are independent in their ADLs, independent ambulating. 1/3 have chronic disability but are able to function, and 1/3 have a poor outcome in which they are essentially wheelchair bound. Mortality is low. Mortality, thankfully, is around 5%, and it may even be lower than that. So I just wanted to show you some of the clinical data that we've looked at. Is there a level which is most common? There is, actually. It seems to cluster. What you're looking at is what spinal level was involved. Cervical, thoracic, lumbar, sacral. There is a clustering around T2 to T6. And we'll talk about what that might mean in terms of the pathophysiology. Now, there's been a lot of interest from patients, from caregivers, even in the medical literature about vaccination. And so we've asked the question, are more of you vaccinated preceding the transverse myelitis than would be otherwise expected? Now let's compare with multiple sclerosis. Other studies which have been done have shown that a recent study that came out in the New England Journal of Medicine, 2.3% of patients with MS had been vaccinated in the 2 months preceding this evaluation. And by contrast with transverse myelitis, it's a much higher percentage. So depending on how we evaluate the data, between 15 and 19% report being vaccinated within 2 months prior to the onset of symptoms. And I think many of you will say that's what caused it. And we don't know that, but there seems to be a higher incidence, at least in transverse myelitis. We've got to go check that. And what I would not say at this point is don't get your vaccinations, because vaccinations save lives and not getting vaccinations kills. But this is a controversial point that we're looking at. How many of you have had an antecedent illness, something that came first, an upper respiratory tract infection, a diarrheal illness? Basically about 1/3 in most studies. We're about the same. So we found about 35% of patients had reported an upper respiratory tract or a diarrheal illness within 3 months prior to the onset of symptoms. Again, we don't know exactly what that means. Did this generate an immune response which became very active and cross-reacted into the spinal cord and induced the damage? We don't know that yet. We know that most of these occur within 30 days. You can see the curve here. Most of these antecedent illnesses occurred within 30 days. Now, is there a relationship to trauma? Many of you, if I asked you to raise hands, would say that there was a trauma, something that happened that preceded the onset of symptoms. A back sprain, a pull, a pop, something like that. And we don't know how important it is, but we've asked. And when we go back through the literature, you find that it's up to maybe 10% of cases, although many cases it's 0. And what we found is a much higher percentage. So if you ask patients if they have had trauma, mild back strain, immediately preceding the onset of symptoms, the answer is yes, in about 1/3. The average was about 9 days prior to the onset of illness, with 57% of those who reported yes, it occurred within 4 days. So finally, does it recur? Because it's a critical issue. For those of you who have had transverse myelitis, one of your big concerns is, will it come back? And it may, but it depends on the subtype of the transverse myelitis. If indeed there are features in the acute phase which say, hey, we're really worried about multiple sclerosis here, it may. It may recur. In fact, most will. If, by contrast, we are able to say there are no features suggestive of multiple sclerosis, the chance of recurrence is certainly much, much lower. In our case, in our database, recurrence we defined as all cases in which there is recurrent clinical symptoms attributable to spinal cord, and they must have a return to abnormal spinal fluid and MRI. So we must have some evidence by spinal fluid or MRI that we've now had a new inflammatory attack. And if you use that criteria, 14% of our patients have had a recurrence. We're starting to analyze that more carefully because the critical question is, can we predict? We don't know that yet, but that's what we're working on. Can we predict who will and who won't? And I'm going to stop there. And that, again, that's Caroline dressing up. She's now 2 years old. So I will take questions. Nurses? So the question is, have I checked nurses? I'm guessing that you would ask because of their exposure to a bunch of infectious agents treating people who are sick. We have not looked at that. An interesting thought. We have not looked at it. A question?
Is there any way to study whether methods of vaccination, even as a child, individual, could have some of their triggers?
So the question is there any way that we can look at if a vaccination given to a child...
No, given to an adult as a child. For instance, when I was a child, I got live viruses from the smallpox vaccination. Could something from stress factor have triggered that?
So the question is about vaccinations, and if, as an adult now, is there some kind of a footprint? Is there some way you can look if the vaccination given as a child a long time ago is still in your system? it's very difficult to look at, but the answer is that it's unlikely that there's any kind of live virus from vaccines that are still around. It is, even for the live vaccine, it's a very transient event. The virus is then cleared. There is an immune response against that agent. That's the role of the vaccination, and that can be detected. But if there is a relationship, we've got to define what subtype, what went wrong, because vaccinations in general are incredibly safe and are really, really, really important. Question?
Yes, I had a vaccination, the first flu vaccination I ever had in my life. Got it at work, it was medical, within 3 days. I had something around my back, went down my leg, real slow, like it was bleeding down here, and then the numbness started. I had a back problem, and I thought I had been over to take shoes off, and I thought I hurt my back, and I was going to chiropractor. Anyhow, I'm pretty sure that's what did it to me because I was really healthy and didn't have anything wrong with me. But what I really wanted to say about the reoccurrence, I had to have, and I didn't know, both of my side nerves, the lumbar cord and the lumbar spine had fallen down on it, and I didn't know it until they did an MRI on it. So I had an operation to repair that, and it was like I had heme all over it.
You know what? I definitely want to talk about that, so we can talk afterwards. I want to get some of that information from you. Question? The first question was stress. Is stress related? I don't know the answer to that. I struggle with how we'd ask that, because if we asked all of you who has had stress in the preceding 2 months, I would be shocked if it's not 100. I really would. And I need to figure out who said no to that question. So how we go to quantitate that, I think, is very difficult. But I think it's important. And the other comment that he made was about nurses, and it's something that maybe we can look at. We've got, I think, 2 more minutes. Spinal cord reduction. You mean in the caliber of the spinal cord? We don't know the answer to it. We know that it is a sign of fairly severe injury. Not yet. You will hear some from Dr. Beauchamp, I think, who will talk about that a bit, and we're starting to look at it, but I don't think we know the data. Brian? Kudevic's or Devick's disease, although I think you'll argue that it may be very, very different. The first question was, did we break it down into people who had complete versus incomplete? And we're doing that, and I think that's a very valid way to subtype. We don't know yet. One more question? I don't know. I'm dying to find that out. I do. Oh, question. Sorry, I should repeat it. Imuran. From the patients, can anybody raise their hand? Who's got Imuran? Is anybody? A few. Looks like there are 3 or 4. It is used with the notion that it can modulate the immune system, and if we've got a recurrent inflammatory attack against the spinal cord, is that a reasonable treatment option to consider? I think it is reasonable, but we don't know. We don't have the data to support its use, but we do. I got to move on. We have to have Dr. Mandler come up. Dr. Mandler's come up from George Washington, and we appreciate him coming very much.